we can go to another tougher and another challenging subject, what's called heart rate with preserved ejection fraction and mid-range in clinical characteristics and the profile of this issue, and the therapeutics also. And I honor to present our professor Lars Lund, and he was working in the most north of Karolinska at Stockholm. I know, is it you are from Lund, the city, Professor Lars? Okay, go ahead.
Yes, hello, thank you. No, I am from Stockholm, but my last name is like the university in the south of Sweden.
It's a very quiet city. I have been there 35 years ago.
Yeah, good, terrific. So can you see my slide, the Heart Failure Summit slide, the blue slide?
Yes, sure.
Terrific, good, okay. Good, so it's a pleasure for me to speak about heart failure with preserved and mildly reduced ejection fraction. What are the clinical characteristics and what are the potential for therapy? And I'll build on Mark's discussion and the questions that you all had for Mark. So I'm going to do a laser pointer here also. So if we look at what are the challenges for us in 2020, in HFrEF, I think we have to now state that treatment really does exist, but it's not implemented. So the main challenge in HFrEF is to implement existing therapy. In heart failure with mildly reduced and preserved ejection fraction, we don't have any evidence-based treatment, and this has been categorized as the greatest unmet need in cardiovascular medicine. And we'll get into some of the nuances, some of the differences between mildly reduced and preserved ejection fraction. And similarly, in acute decompensated heart failure, we don't have any evidence-based treatment. We have lots of treatments, but we don't know how to use them. So let's focus now on HFpEF, which is in blue here, over 50%, a rapidly increasing proportion of all heart failure, while HFrEF is decreasing, and heart failure with mildly reduced ejection fraction is about flat and increasing relatively to HFrEF, because we're treating myocardial infarction earlier and we're treating it better. So what is, looking back, how did we come onto this entity of HFpEF? Well, back in the 1980s, top left, there were a couple of articles speaking about a heart failure syndrome with normal systolic function. HFnEF, we even called it. And then with the increased use of invasive monitoring, invasive catheterization and measurements, we began to talk about diastole, diastolic heart failure, and demonstrated abnormalities in relaxation and stiffness. But recognizing, as Mark said, that it's much more complex than this, we moved on to diagnostic criteria focusing on structure and function. So in the 2016 guidelines, and I don't think this will be much changed, we had the 3 EF categories of reduced, mildly reduced, which was then called mid-range, but I think mildly reduced is a better term, and then preserved ejection fraction, where in all cases we needed an echocardiogram, and in mid-range and preserved ejection fraction we needed also some structural and functional abnormalities, such as increased left atrial volume or left ventricular mass. So what did we do with this knowledge? What is the treatment? Well, there have been 5 trials that have been overall neutral. And it's important to point out that they have been overall neutral. And this is CHARM preserved with ARB, PEP-CHF ACE inhibitor, I-preserve ARB, TOPCAT MRA, and Paragon most recently with sacubitril valsartan. But after these trials and before Paragon, we began to recognize this distinct category, heart failure with mid-range, it was called then, and mildly reduced, it will be called in the future, with an EF of 40 to 49%. It's not normal, but it's no evidence-based therapy. So it's unique in this sense. In the 2012 guidelines, we began to talk about a gray area. Subsequently, Scott Solomon and Carolyn Lamb brought up this middle child And I emphasize that understanding of this middle child or mildly reduced was a great opportunity because it allowed us to distinguish between all the complex different phenotypes in HFpEF. And in the 2016 guidelines, the purpose of identifying this mid-range category was to stimulate research. And since then, indeed, has there been a lot of research on heart failure with mid-range or more preferably mildly reduced ejection fraction. So in a very brief summary, this slide shows reduced ejection fraction, mildly reduced ejection fraction, and preserved ejection fraction. And clinically, by and large, mildly reduced ejection fraction is in some ways intermediate, but in many ways more similar to HFrEF. Of course, the ejection fraction is an imprecise measurement with a variability of plus minus 5 to 7%, but nevertheless, it is what we have, it is what we use. And by and large, in large epidemiological, large registry studies, we see that the age is much younger in reduced and mildly reduced. The percentage of women is much lower. The percentage of ischemic heart disease is much higher. The percentage of AF is much lower, and the blood pressure is lower. Whereas in preserved ejection fraction, there are many more women, age is higher, and actually CKD is more present, interestingly. Now, there is one way in which mildly reduced resembles preserved, and this causes a lot of confusion. Mildly reduced is milder. The NT-proBNP levels are lower in mildly reduced than in reduced ejection fraction. The cardiovascular risk is much lower because the ejection fraction is higher, the NT-proBNP is lower. These patients have less severe heart failure and have a lower cardiovascular risk. So the cardiovascular risk is similar in these two groups, the mildly reduced and the preserved ejection fraction. The non-cardiovascular risk, however, is highest in the preserved group, whereas it's lower in the reduced and the mildly reduced ejection fraction. So armed with this information on the clinical characteristics of mildly reduced ejection fraction, let's take another look, a second look, a post-hoc look at treatment. This is from CHARM, a post-hoc analysis showing a distinct benefit in HFrEF, the same benefit in mildly reduced, and no benefit in preserved ejection fraction, suggesting that taking these two together, there was no effect overall in CHARM preserved, and the trends or the hints of benefit we saw was seen only in this mildly reduced group. As Mark alluded to, this holds also for beta blockers, importantly, in sinus rhythm, in this this collaborative meta-analysis effort, and where all-cause mortality and CV mortality is improved by beta blockers in HFrEF to the left, in mildly reduced ejection fraction in the middle, but not at all in preserved ejection fraction to the right. Similarly, we don't have as strong data, but there are hints of the same observation in TopCat, where on a continuous basis, as ejection fraction increases from left to right, spironolactone appears to have an effect in the lower spectrum of ejection fraction on the primary outcome and on heart failure hospitalization, but not on CV death and certainly not on all-cause death. And then finally, the most robust evidence for this effect in mildly reduced ejection fraction comes from the Paragon Trial, where in the pre-specified subgroup analysis dividing by below and above median ejection fraction, there was a distinct benefit in patients with below median, in this case 57%, and no benefit at all in patients above median, in this case 57%. So taken together, these findings suggest then that many of the existing drugs in HFrEF may be effective also in mildly reduced ejection fraction. And this is an example of an ongoing trial, a pragmatic registry-based trial trying to assess spironolactone in mildly reduced and also in preserved ejection fraction. It's a Swedish-American trial using registries and pragmatic enrollment, randomization, and to assess cardiovascular outcomes and heart failure hospitalizations with spironolactone. So in mildly reduced ejection fraction, we have now added the potential therapeutic benefits. We know clearly in reduced ejection fraction, ARBs, MRAs, potentially, in reduced, yes, beta blockers and ARNI are clearly effective in reduced ejection fraction. They are also likely, based on post-hoc analyses, effective in the mildly reduced. And the relative benefit is similar, about 20% risk reduction. The absolute effect, of course, is lower. The numbers needed to treat is higher because the mid-range or mildly reduced have lower risk. And in completely normal ejection fraction, there is no effect. So we really need to look for something different when the ejection fraction is completely normal. And first, when the ejection fraction is completely normal, how do we diagnose heart failure? Well, apart from the guidelines, there are two approaches or two scores that have been recently published. One is a very epidemiologically oriented H2-FPEF score, which simply establishes a likelihood based on the presence of obesity, hypertension, atrial fibrillation, pulmonary hypertension, and higher age and filling pressures on echo. The more of this, the more likely. The ESC HFA-PEF score looks in much more detail and directs patients into likely, unlikely, and intermediate, where the intermediate would benefit from additional invasive testing. What this means for pathophysiology and future therapy could be summarized, I think, in this slide, in which we look in the middle at HFrEF and mildly reduced, in which the first thing that happens is a direct myocardial injury, leading to necrosis and apoptosis, LV remodeling, neuroendocrine activation, and secondary changes in the interstitium in the form of fibrosis. The opposite is true in HFpEF. Comorbidities such as obesity and diabetes, they drive a global systemic inflammatory state affecting all organs, including the heart, endothelial function and microvascular function, which have secondary changes in the cardiomyocyte, leading to increased stiffness, reduced relaxation, and actually reduced contractility when measured with strain. So the hypothesis that emerges here is that HFpEF is either specific syndromes we're learning, such as amyloidosis or hypertrophic cardiomyopathy, or it's a more general syndrome driven by comorbidities. And the emerging treatments for this might be SGLT2 inhibitors, as we have addressed, and potentially also anti-inflammatory therapy. There are multiple efforts in early phase 1 and 2 targeting true HFpEF and this inflammatory syndrome. In HFrEF instead, we have the atrial fibrillation and cardiorenal syndrome are largely secondary changes to the hemodynamic perturbations. So one interesting, very recent development is sotagliflozin, which is SGLT2 and also 1 inhibitor, which was tested in soloists, I think Mark mentioned this, in all EF groups. Heart failure regardless of ejection fraction, and starting in hospital in acute heart failure and shortly after hospitalization. Despite the small sample size, a dramatic effect on the primary endpoint as well as other endpoints. So this is the first randomized data suggesting that SGLT2 inhibitors have broad applicability across the ejection fraction spectrum in heart failure including acute heart failure. So if we summarize heart failure with mid-range and preserved or mildly reduced and preserved ejection fraction, both are heart failure syndromes in the sense of elevated filling pressures and signs and symptoms of heart failure. Mildly reduced is similar to reduced, but it's milder and has a better prognosis. In mildly reduced, there is some incremental evidence that I think in the future may support a recommendation to consider existing therapy, a weak recommendation based on post hoc and subgroup analyses, as well as ongoing trials. Whereas in HFpEF, we will look for new targets. SGLT2 inhibitors is a new mechanistic approach to heart failure across the ejection fraction spectrum, targeting specific syndromes such as amyloidosis, and also targeting the global comorbidity-driven inflammation. Thank you.
Thank you very much, Lars. Lars, can you define the heart failure preserved ejection fraction and classify it into different phenotypes, or it is only one category?
Right. So in terms of definitions, it is not possible to characterize into different phenotypes, diagnostic. But in terms of pathophysiology, absolutely yes. There's no doubt now that, for example, amyloidosis, which was TTR amyloidosis, which was previously not recognized, is quite common in patients with heart failure and a normal ejection fraction. Over 10%, possibly close to 20%, have amyloidosis in the background. There are also other specific syndromes, hypertrophic cardiomyopathy with no obvious diagnosis of hypertrophic cardiomyopathy nevertheless contributes. There's also the HFpEF-PH, where there's predominantly a inflammation-driven change in the pulmonary vasculature in right-sided heart failure. So there's lots of methods to phenotype HFpEF, and this is clearly necessary when we embark on new strategies. For example, I'm involved in developing novel treatments based on the inflammatory paradigm. And in this case, we really are trying to phenotype patients based on proteomics and other biomarkers of an inflammatory state. So yes, there are clearly several HFpEF phenotypes, and these need to be clarified and targeted more specifically than they have been so far.
Okay, let me, Dr. Mahmoud Hassanin, it seems you have a question. Dr. Mahmoud?
Yes, please. Thank you very much for the great presentation. I would like to ask you, don't you think that we should rename heart failure with mid-range ejection fraction to heart failure with mildly reduced ejection fraction, since you have told us they look very similar to heart failure with reduced ejection fraction, and they respond to the same therapies of heart failure with reduced ejection fraction? The second point is that don't you think that the Paragon Trial has shaken our beliefs about the cutoff points of ejection fraction, I mean classification of heart failure according to the ejection fraction, since patients responded to therapies if the ejection fraction was less than 57%, a new boundary for ejection fraction?
Yes. The answer is yes to both questions. I'm a strong proponent of renaming mid-range to mildly reduced. And I do think that this will happen in future guidelines and consensus statements. There is one drawback, only one, and that is that remember that many treating clinicians are not familiar with even MREF or mid-range. So to keep changing, to keep moving the target can be confusing to primary care, general medicine, general cardiology. But I still advocate changing to mildly reduced because it is so much more clearly consistent with the pathophysiology, clinical characteristics, and effects of therapy. Similarly, I think Paragon really nailed that concept, because the Paragon subgroup analysis is only a subgroup analysis, but it is so consistent with everything else we know. A subgroup analysis based on ejection fraction, I think, can be interpreted, suggesting that there is strong evidence that ARNI, or sacubitril/valsartan, is effective in an ejection fraction up to 50, 55, or even 60, higher in women. And that is because other drugs appear to be effective the same way. That is because the clinical characteristics are very similar. So there is a reason to believe that this subgroup is not a finding based on chance, but based on pathophysiology.
Dear Lars, please, I have a question for you. There are many clinically variables in HFrEF, like the heart failure biomarkers, imaging, genotypes, metabolomics, proteomics. Which one is easier and relevant for a busy cardiologist?
Okay, I'm not sure if I heard it. Was the question what sort of testing, diagnostics can be? Yeah, well, so it's interesting. I think you mentioned the peak VO2 or the VO2 max. The VO2 max has been validated in heart failure across the ejection fraction spectrum. And there are numerous aspects that are the same for heart failure throughout the spectrum. These are related to filling pressures and hemodynamics. So natriuretic peptides, they're lower in HFpEF, but they're equally diagnostic and prognostic. Right heart catheterization is very helpful in HFpEF, particularly during exercise, and the peak VO2 also. And in addition to that, there are emerging imaging parameters focusing on the left atrium, focusing on systolic aspects other than ejection fraction, such as strain imaging analysis.
Thank you very much, Lars, and see you at night today. Okay? Be ready for us.
Yes.
Goodbye.
Thank you.
Thank you.